Hello class, I'm going to talk about the medications for week 5. They have to do with GI medications, meds that are prescribed for irritable bowel syndrome, peptic ulcer disease, and for GERD. I just want to preface some information before we get on with the medications, just to kind of review some of the normal anatomy and physiology of the GI tract. We see in today's populations a lot of GI problems that people have. There are acid-related diseases of the upper GI tract, and many people use over-the-counter meds that essentially help with some of their symptoms. But sometimes when people develop these problems with the upper GI tract, they can be related to more serious problems. We see people often develop peptic ulcers, whether it's in the duodenum or in the stomach itself. Remember where the duodenum is. It's the first 10 inches of the small intestine, and we also have gastric glands in the stomach, and there's chief cells that secrete enzymes and pepsinogen that convert to pepsin, and those break down proteins, and those are those chief cells. And then we have parietal cells that actually secrete hydrochloric acid, and the intrinsic factor that's essential for the absorption of vitamin B12. Your parietal cells are the target for many meds that help reduce that acid secretion. And parietal cells get messaged to either increase or decrease acid production. And there's receptors for gastrin, histamine, and neurotransmitters such as acetylcholine. And indigestion of food, distension of stomach, cause gastrin into the bloodstream, and also histamine as well. And cells lining the stomach actually secrete mucosa that is a protective barrier against acid, which, break down the lining of the stomach, causing someone to develop some type of ulcer. We also have bicarbonate ions, which are secreted by the epithelial cells, and there's also prostaglandin E2, which stimulates the secretion of mucus, bicarbonate, and helps promote the repair of the damaged gastric mucosal cells. Now let's talk a little bit about peptic ulcer disease. A peptic ulcer is a lesion or an erosion. It can either be in the stomach, gastric ulcer, or in the small intestine, which we refer to as a duodenal ulcer. And with this ulcer, there's an acute inflammatory process that occurs. It really is the disease of modern civilization, the 19th century. A lot of people get them because they have some of the many risk factors. Obviously, the first one is an infection with bacterium Helicobacter pylori, or H. pylori. Maybe they have a close family history of peptic ulcer disease. Many drugs that they take, even if they are prescribed, such as corticosteroids, NSAIDs, aspirin, some of your antiplatelet meds like Plavix for people that have heart disease and have to have, stents put in. Blood group O, people who smoke, people who drink a lot of coffee or intake of excessive caffeine, and all kinds of psychological stress. About 4.5 million people in this country suffer from peptic ulcer disease, and NSAIDs, intaking those types of medications cause about half peptic ulcers. Symptoms of duodenal ulcers. A person may have a gnawing or burning type of increased abdominal pain or upper abdominal pain about 1 to 3 hours after they have a meal. The pain for a duodenal ulcer gets worse when the stomach is empty. Gastric ulcers are less common. but the pain is relieved with food. And many times with gastric ulcers, people experience anorexia, weight loss, and vomiting. Then we also have the Zollinger-Ellison syndrome, and this is a less common cause of peptic ulcer disease. It's caused by a gastrinoma, a tumor of the pancreas or duodenum that secretes large amounts of the hormone gastrin. And we see sometimes people with ulcerations in the distal small intestine where they develop Crohn's disease, and we see erosions in the large intestine where they develop ulcerative colitis known as irritable bowel syndrome. And then we do have people that develop what we call GERDs, which is gastric esophageal reflux disease, where acid comes up from the stomach and enters into the esophagus. The reason this happens with many adults is there's a weakening or relaxation of the specialized muscle segment at the end of the esophagus, and that's where people may say they have what they call heartburn. Things that make it worse are certain medications. Some foods can really make it worse. The reason we worry about people with chronic heartburn is there are complications. About 10% of people who have GERDs or heartburn develop what we call Barrett's syndrome or Barrett's esophagus, and this is known to be a precursor for people who get esophageal cancer. So, treatment of GERDs, sometimes it's just a matter of changing lifestyle factors, trying to stop smoking and drinking no alcohol. So that's why it takes us into talking about some of the medications. It's not that bad this week. There's only about 5 of them, but I want to make sure that you understand them because we're giving a prototype of each type of example. I made up this PowerPoint just to kind of help you keep your thoughts in check about the medications and the therapeutic and pharmacological classification of each. All right, our first med that we're going to talk about is dicyclomine. It's also known as Bentyl. This has been around for a long time. It was approved back in the 1950s. It can be given either PO or IM. Therapeutically, it's an antispasmodic, and pharmacologically, it's an anticholinergic. And what it does is it reduces bowel spasms and helps to treat irritable bowel syndrome. And how it works is it relaxes smooth muscle and it slows down peristalsis. So that's why it kind of treats people who have irritable bowel that, have a lot of diarrhea and problems like that. Now remember, because of its anticholinergic effects, you're going to get some of those adverse reactions from that classification of medications like dry mouth, blurred vision, drowsiness, urinary hesitancy, and tachycardia. Again, as with any patient, when they have been diagnosed with some of these GI problems, such as IBS, it's important to understand and assess their medical history, including bowel and urinary history. Assess what medications your patients are taking. Are they taking them faithfully? Taking them the way they are prescribed? Assess any chances of women being pregnant, and if they've just recently had a baby, are they lactating? Are they breastfeeding? Assess vital signs in patients' weights, look at some of the labs, assess abdomen, and check to see if they're having any allergic or adverse reactions, and just see how they're doing with whatever medications that they're on. So that's dicyclomine. The next med is sucralfate. It's also known as Carafate. Therapeutically, it's an anti-ulcer drug to treat peptic ulcer disease. It's a medication given orally, PO, for peptic ulcer disease, for GERDs, used in critical patients to prevent bleeding from stress-related gastritis. This is not a medication that we should give for someone who develops an ulcer that's caused by NSAIDs. What it does is it consists of sucrose and aluminum hydroxide, which stimulates mucus, bicarbonate, and those prostaglandin secretions, all of which help to enhance mucosal defenses, and it helps to provide a thick barrier to coat and bind the ulcer, protecting it from further erosion, from acid and pepsin, to also promote healing. All right, this is a fairly safe drug. I take this personally. I've had some ulcers in the past, and I do take a sucralfate on occasion. Probably the biggest side effect with this is constipation, and it can bind to other drugs and decrease their absorption, such as digoxin and warfarin and some of the quinolones, those antibiotics, phenytoin, and tetracyclines. If the patient is also taking antacids to treat their GI problems, it's recommended that antacids and other meds should be taken about 2 hours before and after, so they're the effect of sucralfate is not affected. And in order to be as optimally effective with a patient who develops some type of ulcer, it should be taken 4 times a day, and basically on an empty stomach. Again, assessing their medical history of what kind of GI problems they have, assess labs, and patient might need to be tested for H. pylori. Of course, always assessing abdomen and any type of allergic and adverse responses. But for the most part, sucralfate is essentially fairly safe. Like I said, probably the biggest problem we see with this is constipation. But again, always know what other medications your patients are taking, so that we make sure that the patients are not taking that at the same time they're taking their sucralfate. It's only to be used for short-term therapy, up to 8 weeks, and it really requires an acid medium to work effectively. Okay, so that's sucralfate. The next med is a med you're probably familiar with, because now we can purchase this over the counter. It's omeprazole, and this is also known as Prilosec. Therapeutically, it's an anti-ulcer, but it's also a protein pump inhibitor. What is recommended when someone has been diagnosed with a duodenal or gastric ulcer? This is usually prescribed. Patient is to take it for approximately 4 to 8 weeks, and it helps with not only ulcers, but anybody with GERDs, erosive esophagitis, heartburn, maintenance of erosive esophagitis, somebody that just always has that inflammation to their esophagus. It also can be used in patients with prevent peptic ulcer disease in patients who are taking NSAIDs. May be used in ZES or Zollinger-Ellison syndrome, tumors of the GI tract. And with patients who have been diagnosed with the H. pylori, we would give this in combination with antibiotics. It inhibits, again, the final pathway involved in acid secretions, and effectively inhibits the active protein pump inhibitor. Okay. Let me go to the next one. How it works is with protein pump inhibitors, reduces acid secretion in the stomach by binding irreversibly to the enzymes H+, K+, and ATPase. Some of the adverse effects that we see with omeprazole is it has been known to be linked to C. diff, can also cause vitamin B12 deficiencies when patients are on these for other reasons, because of cardiac issues. Maybe they've had a stent and have to be on some kind of antiplatelet meds. It will reduce the effectiveness of those meds, such as Plavix. And if it's given or used with warfarin, it increases bleeding risk, and again increases the risk for osteoporosis. So patients may have related fractures of the hip, the wrist, the spine. It should only be prescribed for short-term 4 to 8 weeks therapy. This has been around a long time. It was approved back in 1989. Usually the suggested prescribed dose is about 20 to 60 milligrams daily BID. And usually the dosage that you buy over the counter are 20 milligram tablets. So it can get kind of expensive. So if you're going to be on this for a long term, it's really suggested that a physician writes out a prescription. And then if you have insurance to cover prescriptions, it would probably be more economical to do it that way than to buy this over the counter. Because like I said, the tablets over the counter are only 20 milligrams, and you might have to take 2 or 3 of those to achieve the prescribed amount that the physician orders for you. All right, the next medication is another common protein pump inhibitor, esomeprazole, and we also know this better as Nexium. Again, works in the same way, suppresses gastric acid secretion by specific inhibition of the H+, K+, ATPase in the gastric parietal cell, okay, as I talked about earlier. Again, recommended for a patient that might have some of these problems with the GI tract. Adults, 20 to 40 milligrams once a day for 4 to 8 weeks. This is also a med that can be given IV as well. Some of the adverse effects are headache, drowsiness, mild diarrhea, stomach pain, gas, and constipation. So now we have the last med called cimetidine, and this is commonly known as Tagamet. And it is one of those H2 receptor antagonists. And this works a little bit different, reduces the amount of acid in your stomach, which suppresses the volume and acidity of the parietal cells. When given this PO for an active ulcer, the recommended dosage is 300 milligrams every 6 hours or 800 milligrams in HS. And when it's used for GERD, 400 milligrams every 6 hours or 800 milligrams BID. Some of the adverse effects are headache, fatigue, gynecomastia, especially with males, and some of the rare adverse effects are hepatitis, blood dyscrasias, galactorrhea, and confusion and psychosis. But those rarely do happen, but it's also important to know that that is a possibility as well. So that's an example or a prototype from that group of medications, okay? So that's really all the medications that I wanted to talk to you about this week. It's not too bad. Hopefully you'll have had your lecture that relates to why these medications are prescribed, such as peptic ulcers disease, GERD, and heartburn, and irritable bowel syndrome as well. And you'll understand why many of these are prescribed for your patients, okay? But as always, with all medications, there's always the possibility of side effects. I also want to remind you to go into your DA book. Since the meds are not that heavy this week, I want to be sure that you're all able to do the problems that relate to milliliters per hour, drops per minute, and time, infusion time, and then completion time, okay? I talked a little bit about this on last week's online lecture, but you've got to get into your DA book and practice the problems, because not only is it important that you get the correct dosage calculation, because really it's about safety. It's about administering the correct amount of medication to a patient. But you've got to learn how to set these up quickly. You have to be able to critically think and pull the information from the problem and know right away how to set it up. What you put as a numerator, what you put as a denominator, okay? As I said last week, to calculate drops per minute. And why would we do that? We would do that when we don't have a patient's IV medication or IV solution for hydration. It's not on a pump, so we actually have to count the drops per minute, and that will give us how many milliliters an hour the patient will have that particular solution infused. This is the way I used to do it back in the olden days. We didn't put everything on a pump, which I know was not safe. But there may be a case or a time where a patient doesn't have their medication or their IV on a pump, and you have to count those drops. In order to do that, you need 3 variables to be included in the problem. That is, what's the drip factor or the drop factor of the tubing that you're using. It can come in all different types of drop factor. You can have tubing that might give 10 drops per milliliter. You may have 20 drops per milliliter, 15 drops per milliliter. If you have, we consider that macro drips. And then you might have a micro drip, where probably the most common one is 60 drops per milliliter. So you need that information in order to be able to determine drops per minute. And so then when that's given to you in the problem, then you need to know how much solution you're going to infuse and over what period of time. So maybe it's an IV of 800 milliliters over 6 hours. So you have those 3 variables given to you, then you are able to set up the problem, okay? Always remember too, you want to finish the problem completely. And that means if you by some chance, when you're figuring out time problems and you get 7.33 hours, you want to take that 0.33 and multiply that by 60, and you'll get 7 hours and so many minutes. You don't want to leave it 7.33 hours, because we need to feasibly understand how much is 0.33 of an hour. It's a little over 1/3 of an hour, so you're thinking maybe it's going to be over 20 minutes, but you want that specific amount of minutes. So always finish the problem when you're doing time problems. Take that 0.33 or 0.42 and multiply it by 60, and you'll get 7 hours and 26 minutes. I know it's not always important to know the exact minute when an infusion will be completed, but at least it gives you an idea of when that solution will be done, that you can have that next bag ready to go. All right, so I want to make sure that you're doing this. I also want to be sure that you're understanding rounding. I was very lenient on test 1 about how you were able to round your answers. You want to look at the answer and say, can I feasibly give that much medication? Because when we're talking about hundreds place, that's a small amount of medication, and we don't know how specific and how accurate we can be with that. So that's why if you come up with, 2.78 milliliters, you'd want to round that 7.8 to 2.8. Okay, we could give 2.8 milliliters of medication, especially, if it's IV push or whatever the route is. That's the kind of stuff I want you to feasibly look at, because I don't want you to think of these calculations as math problems. Yeah, you have to do math by multiplication and division and things like that, but it's really about providing the patient the correct amount of medication that's been ordered for him. And many times you can critically think and know that it's going to be approximately less than a milliliter, depending on what concentration of medication you have in a vial or an ampule or whatever, okay? I also want to be sure that you have looked over that Mars practice sheet from week 4. It gave you some really great practice with AccuChecks, and we will be doing that in lab when we hopefully get to meet in the summer and we do the 124 lab. We will practice AccuChecks, okay? Because we want to make sure our patients are doing their AccuChecks and that they you know, are very aware of what their blood sugars are running, especially anytime we're going to give them insulin or they're going to give themselves insulin. This insulin practice on week 4 really gives you practice with sliding scales, okay? And this is very often what you may see in a doctor's order, so you want to be sure that you're interpreting that information correctly from the medication administration record or from the MARS. Always know what your patient's allergies are so that we can be sure that no medications that have that particular med in it is being given to your patients. Sometimes the MARS will have definite protocols where you know, a type of insulin may be ordered and you would hold it for a blood sugar less than 100 milligrams per deciliter. Again, this insulin practice sheet really gives you the ability to critically think about what to do, especially if you see that your patient is developing signs and symptoms of hypoglycemia. So I want to be sure that you have reviewed that and you're prepared to answer similar questions on your test 2, which will be in week 7. There is a hypoglycemia protocol on this practice MARS as well, saying what would you do for a patient who's conscious if the blood sugar is below 70, or a patient that is unconscious or uncooperative, or a patient that is NPO. What would you do for that patient when they are experiencing hyperglycemia? Hypoglycemia is a diabetic emergency, and you need to intervene as quickly as possible, because being that it's an emergency, a patient can actually die from a low blood sugar. So I'm stressing the importance of reviewing this and looking at some of the medications that we might treat hypoglycemia with, such as some of your fast-acting glucose, 50% dextrose, or even a glucagon injection as well. Now, please refer to your DA book. I didn't assign it, but I would suggest that on page 293 in your DA book, your Horvet book, 293, there is a section on insulin administration, at least to look at some of the glossary terms. I talked a little bit about basal and prandial when I discussed the medications last week. You've already had your lecture now on diabetes, or at least you're concluding your lecture from Nursing 122 on diabetes. But talking about actually what insulin is, and we've definitely gone over the various types of insulin and how they work, and the onset, the peak, and the duration, and then looking at sliding scales as well. And then it would be probably advisable to do some of the practice questions on insulin types and orders, which is on page 297. So, and then it talks about insulin delivery systems using insulin syringes and obviously insulin vials, that they all should be compatible with whatever number the syringe is. That's what the insulin vial should be as well. And one of the common ones is U100. And also mixing insulins. There is a big yellow box on page 305 that has how you would mix NPH insulin with regular or rapid acting insulin, what the procedure for that would be. So just some very helpful hints, and practice MARS with that as well. So you do have the resources to be able to review this. I know it's a lot when you're doing Nursing 122 lecture and lab but you do not have 124 lab now. So I really want you to get the most out of your meaning, out of the information and meaning from all the information related to diabetes. It's huge, guys. You're going to have a lot of patients with diabetes, and I'm going to suggest that you really understand that disease process and all the teaching and education that goes with it. And we're better nurses when we understand diabetes and how this has specifically affected our particular patients that we care for. Because whatever we know, we can, in a simplistic fashion, provide that information to our patients. Because honestly, this is a treacherous disease, and with little knowledge that patients have with diabetes, this is where they run into all the serious complications down the road. And of course, there's serious complications which will affect the longevity of their life, causing them to have a lot of the retinopathies, kidney issues, cardiovascular issues, and all that. So I'm trying to give you a great foundation, as well as your lecture instructor for Nursing 122. It's a disease that we ourselves have to be more knowledgeable about to be better equipped to care for the patients that have diabetes and to spot the initial problems to prevent the serious complications, okay, and prevent serious diabetic emergencies from occurring. And part of the way we treat our diabetics is through medication and through good education as well. Okay, so that's all I have for you this week. A little review of last week, but again, understanding these meds for GI problems such as peptic ulcer disease, irritable bowel syndrome, and GERD. And so please let me know if you have any questions. I just created this little PowerPoint as well. So I hope you're having a great weekend and a great week. So thank you for your attention, and thank you all for doing such a great job with this course. I appreciate all your hard work and effort that you're putting into learning your meds that are definitely related to the pathology that you're given from your Nursing 122 lecture. Take care, and I'm here for you if you need anything. Have a great evening.